Dr. Lwin, first-year resident, will be doing the first presentation.
Okay, so today we'll talk about a treatment that is widely recommended for lactic acidosis. The objectives for today will define lactic acidosis and its adverse effects. We'll examine the evidence for the use of sodium bicarbonate in the treatment of lactic acidosis, as well as the future of research in regard to sodium bicarbonate in the use of lactic acidosis and metabolic acidosis in general. So currently, lactic acidosis is defined in clinical practice as a pH less than 7.35, a lactate level greater than 2, and a partial pressure of carbon dioxide less than or equal to 42. Lactic acidosis, as we all have seen, is most commonly seen in sepsis or states of shock. Experimentally, severe acidemia has been shown to reduce cardiac contractility through myocardial cell dysfunction and vascular smooth muscle cell dysfunction and cause hyporesponsiveness to vasopressors. Currently, there are no clinical trials that have established the level at which pH becomes deleterious to hemodynamics. So here I have kind of a visual of the effects of severe lactic acidosis. You see that it describes pH of the intracellular cell as less than 7 and the pH of the extracellular environment as less than 7.2. And here they describe there's a considerable impact on the transient calcium amplitude, which then affects the subsequent excitation and contraction coupling pathway in the myocardial cells. The calcium binding to troponin is altered due to the acidemia, and then the myofilament to calcium sensitivity is decreased. There's also enhanced hyperpolarization through the potassium extrusion out of the cells, as well as promotion of apoptosis. This schematic also describes the ATP production is inhibited and that the extracellular and intracellular acidosis affects the it decreases the number of adrenal receptors on the cell membrane. And so from that, you can conclude that severe acidemia causes a negative impact on cardiac contractility, the sensitivity to adrenergic receptors, and that can lead to circulatory failure and decreased survival. And so it's logical to kind of conclude that treatment of adding a base would help decrease the effects of a low pH. So here, sodium bicarbonate therapy, replacement of sodium bicarb is beneficial in disorders seen with loss of sodium bicarb, such as diarrhea or renal tubular acidosis. But symptomatic treatment with sodium bicarb to correct metabolic acidosis in other settings has not been demonstrated to be a benefit to clinical outcomes or mortality. So the potential dangers of sodium bicarbonate include hypokalemia, hypocalcemia, hypernatremia. Increasing pH can increase the hemoglobin affinity for oxygen, which can decrease oxygen delivery. And then also bicarbonate therapy has been seen to increase carbon dioxide generation, and then that can cause a paradoxical intracellular acidosis and CSF acidosis. So here I kind of go over the pathophysiology of what I mean by paradoxical intracellular acidosis. It can be explained in this equation here, where when you add sodium bicarb, it forms with the proton to form water and carbon dioxide. And if bicarb is administered in large amounts with people with metabolic acidosis, it will increase the formation of carbon dioxide. And so bicarbonate can only increase extracellular pH if there's adequate ventilation to remove the excess CO2 generated from this reaction. Otherwise, carbon dioxide, there is hypercapnia, and then carbon dioxide can easily rapidly diffuse across the cell membrane, whereas bicarbonate cannot. And that produces an intracellular respiratory acidosis. From clinical practice, from the surviving sepsis guidelines, their recommendation is against the use of sodium bicarbonate therapy to improve hemodynamics or to reduce vasopressor requirements in patients with hypoperfusion-induced lactic acidemia with a pH greater than or equal to 7.15. But there was no recommendation for pH levels less than 7.15 on the guidelines. From a survey in 2006, it revealed that 67% of intensivists would recommend the administration of BACE to patients with metabolic acidosis, including lactic acidosis, while 86% of nephrologists would give bicarbonate for treatment of lactic acidosis. And 37% of these intensivists also begin symptomatic treatment of metabolic acidosis for a pH greater than or equal to 7.1. Now, with this observed variability with physicians, it kind of raises the question that we need more studies to generate the data that could support evidence-based guidelines. As far as the evidence in regards to the effect of sodium bicarbonate on cardiovascular function and clinical outcomes in humans, the literature is scarce. And the literature and the evidence I was able to find show no benefit to the use of sodium bicarbonate. We can take a look at this table here. The first study I'd like to talk about is in 2011, a prospective observational multi-center study of 200 patients with severe metabolic acidosis with a pH less than 7.2. 1/3 of these patients received sodium bicarb. The use for sodium bicarb was heterogeneous, and it was not associated with a difference in survival. The caveat to this study was that the study was not designed to determine the impact of sodium bicarb on outcome. The clinicians made the decision to use BACE independently. The next study would be in 2010. 72 patients with septic shock and increased blood lactate received sodium bicarb for a pH less than 7.3 versus conventional therapy. And what that study showed was that there was no reduction to reversal of shock, but it was associated with shorter mechanical ventilation duration and length of stay in the ICU. But the 28-day mortality did not differ between the groups. Of note for that study, the pH for initiation of treatment was higher than what's traditionally recommended, which is 7.1 to 7.2. The next three studies we'll take a look at in more detail. So this 1990 study was one of the two studies cited by the surviving sepsis guidelines as evidence for the recommendation on sodium bicarb use. There were 14 patients who had metabolic acidosis, bicarb less than 17, base excess less than -10, and increased arterial lactate greater than 2.5, all of whom were mechanically ventilated and 13 of whom were on vasopressor support. Each patient received subsequently both bicarb infusion and sodium chloride, but the infusion order was randomized with a 20-minute break in between infusions. The dose was 2 millimoles per kilogram body weight over 15 minutes versus sodium chloride of the equal dose, volume, and time. This study found that correction of acidemia compared to sodium chloride did not improve the hemodynamics or the response to the infused catecholamines. The infusion of bicarb did, however, increase arterial pH, serum bicarb, partial pressure of CO2, and decrease plasma ionized calcium. Of note, the patients were only observed for 2 hours, and the study attributed the BACE therapy failure to partly the increase of partial pressure of CO2 and the decrease in ionized calcium. Next is the second study that was cited by the surviving sepsis guidelines in 1991. So here, 10 patients on mechanical ventilation and vasopressor therapy. The inclusion criteria was that plasma lactate was greater than or equal to 2.45. Metabolic acidosis was determined to be a bicarb less than 22, and no severe renal failure was present. Here, sodium bicarb was given 1 millimole per kilogram of body weight or equal volume of sodium chloride And this was done in 1 hour study periods. And period order was randomized and separated by a 30-minute interval. This study found that bicarb infusion, again, increased arterial pH as well as venous pH, serum bicarb, partial pressure of CO2, but the hemodynamic response for both modalities were similar. Of note here, they did not see any tissue oxygenation difference in either of the modalities, and no changes in serum sodium concentration, osmolality, arterial and venous lactate, or hemoglobin affinity. Here, we look at a more recent study in 2013 on the effect of sodium bicarbonate on the administration of mortality in patients with lactic acidosis. So this was a retrospective single-center analysis from May 2011 to April 2012, and included 103 patients. The inclusion criteria included lactic acidosis above 3.3 with a high anion gap metabolic acidosis and a serum bicarbonate less than 20. 69 of these patients received sodium bicarbonate. And this study found that percentage of sodium bicarbonate administration, catecholamine use, ventilator care, and the male gender were higher in the non-survival group than the survival group. The subgroup analysis, after excluding patients with lower disease severity and the higher initial bicarbonate level, patients treated with bicarbonate still had a higher mortality rate compared to the patients who did not receive sodium bicarbonate. So this study was statistically significant for sodium bicarbonate administration being associated with higher mortality. So they concluded that sodium bicarbonate should be prescribed with caution in the case of lactic acidosis because sodium bicarbonate administration may affect mortality. Notably, the initial pH in the study was 7.27 for the patients, and 75% of the patients were treated with sodium bicarbonate with an initial pH greater than 7.15. Next, we'll be looking more at the recent literature in 2018. This one, it was a retrospective study of a large US-based critical care database called the Medical Information Mart for intensive care, with a total of 1,718 septic patients with metabolic acidosis. And that included 500 patients who were in the sodium bicarbonate group, and then 1,218 in the non-sodium bicarbonate group. The inclusion criteria was that the patients had to have had sepsis, a pH less than 7.3, and a bicarbonate level less than 20, as well as absence of respiratory acidosis. Then afterwards, they used a statistical tool called propensity scores to account for the baseline differences in the probability to receive sodium bicarbonate or not, and then they made 500 pairs in order to do this analysis. And here the conclusion was that both pH and bicarbonate concentration were significantly lower in the sodium bicarbonate group than the non-sodium bicarbonate group. And while there was no significant mortality effect in the overall population with either of the modalities, the sodium bicarbonate group was observed to be beneficial in patients with AKI stage 2 or 3 and a pH less than 7.2. And then of note, there was no statistical difference in sodium bicarb use or in mortality for the subgroup with a pH less than 7.2 and a lactate greater than 2.2. That was a retrospective study, and this was the only randomized control study from 2018 that I could find that correlated actually with the retrospective study. So here it was a multi-center open-label randomized control study from 26 intensive care units in France, a total of 389 patients into the intention to treat analysis were involved. The inclusion criteria included a pH less than or equal to 7.2, a partial pressure of CO2 less than or equal to 45, and a sodium bicarbonate concentration less than or equal to 20, and a total sequential organ failure assessment score of 4 or an arterial lactate of 2 millimoles or more. So of note, the serum lactate for the patients greater than 2.0 at enrollment was 78% in the control group and then 86% for the bicarbonate group, but this was not a subgroup that was analyzed. Either no sodium bicarbonate was given or 4.2% of sodium bicarbonate infusion was given to maintain an arterial pH above 7.3. And just to put that in perspective, 1 amp of bicarb in the hospital contains a tonicity level of 8.4%. And then the study recommended that the volume of each infusion should be within 125 to 250 in 30 minutes with a maximum of 1 liter within 24 hours after inclusion. And they stratified it as age, sepsis status, and AKI network. And the primary outcome was a composite of death from any cause by day 28 and a presence of at least 1 organ failure. Of note, also, the protocol for the control group did not have a specific control solution to use. The primary outcome was seen in 71% of the control group and then 66% of the bicarbonate group, and there was no statistical significance from this. They did a Kaplan-Meier method estimate of the probability of survival at day 28 between the control group and the bicarbonate group. That was also not significant. What was of significance was the pre-specified Aiken stratum of patients with a score of 2 or 3, where they found that between the two groups, the estimate of survival by day 28 was increased in the bicarbonate group compared to the control group. Additionally, the number of days alive and free from renal replacement therapy was higher in the bicarbonate group than in the control group, both in the overall study population and then in the defined stratum of the acute injury, kidney injury patients. The days free from mechanical ventilation was not different for both the overall group and the Aiken 2 to 3 stratum, but the days of free from vasopressor was higher in the bicarbonate group than in the control group, just for the acute injury network 2 to 3 stratum. Also, this study found that metabolic alkalosis, hypernatremia, and hypocalcemia were observed more frequently in the bicarbonate group than in the control group, but no life-threatening complications were reported. As you can see, there's no real statistical analysis on the lactate therapy for the patients, and the paper had noted that there were multiple causes for acidemia in the study. So in conclusion, although bicarbonate therapy is often given in clinical practice and recommended to be administered, there is no evidence for a net beneficial effect of symptomatic sodium bicarbonate use for correction of lactic acidosis. Additionally, the safety or efficacy of sodium bicarbonate is very controversial. Correcting metabolic acidosis with sodium bicarb may negatively affect the recovery from lactic acidosis, especially in patients without severe acidemia at pH less than 7.2. And in theory, hyperventilation to lessen the carbon dioxide accumulation and administration of calcium to stabilize the blood calcium might allow for the positive effects of the bicarbonate therapy to be expressed in future studies. Given the critical importance of this disorder in affecting clinical outcomes in our patients, randomized controlled studies of various treatment regimens, including the protocol for sodium bicarbonate infusion in terms of tonicity or speed of acidemia correction, should be evaluated in future trials to establish more evidence-based approach to treatment. Here are my references. And this is my question.
Okay, so before we vote, I'm sure there'll be comments. Just one quick historical perspective from me. I mean, when I trained initially as a resident, everybody was given bicarb for lactic and metabolic acidosis when the pH was low. By the time I finished my fellowship, some of those early studies were done, and everybody said, don't give it for lactic acidosis because of the potential for increasing or worsening the intracellular acidosis and actually causing more problems. And you can see the evidence over the years has been quite variable, and even the most recent trial, which was not done just in lactic acidosis, is kind of a mixed study, not really showing an overall mortality benefit. So I'm just throwing that in as a perspective, but I'd like to hear other people's thoughts, especially anybody. Dr. Collins.
So did your last study actually show that there was benefit to using bicarb in patients with class 2 or 3 AKI?
Yes.
So can this blanketed statement?
With acidemia less than 7.2.
So there is some benefit in certain population with lactic acidosis.
That's only been demonstrated in 2 trials, one randomized control, and the other one was just a retrospective study. So
Okay.
I would say more data would be needed, but yeah, that's what it's saying right now.
Did we set the bar too high in terms of the pH? I mean, somebody who has a pH of 6.8, I think, is a lot different than somebody at 6.1 or 7.1.
Yeah.
Right, so there were no studies that I could find that kind of delineated, okay, we need to kind of start therapy at this critical number, or this was the most fatal and you shouldn't even wait to get there. Nothing showed what number to kind of decipher when to begin therapy.
On that note, I think it's really interesting when you look at the literature and the guidelines that are promulgated. They say, don't treat above 7.2, but, some say 7.1 if it's below that to treat. Some say 7, some say 7.15. They're all over the place, and basically those are based on no data. All of those recommendations of the lower, where you should maybe start giving bicarb, because there's no data that at any level really that nobody's done those studies really. So no one knows. So it's a controversial area. So I think we're going to vote. Is it a myth? Treatment of lactic acidosis with bicarbonate is beneficial, and clearly this is a mixed picture. And I intentionally didn't word it the way I usually do to come out with a certain outcome, but or I shouldn't say usually, but sometimes do, because I think I still don't really know the answer. I think clearly from the data that's here, in my opinion, from the data that's here, if you have somebody with acute kidney injury, maybe it's beneficial. If you have somebody that isn't, it's probably not. That would be my take on all of this data. But let's vote and see what you guys think. So is this confirmed, plausible, or confirmed, plausible, or busted? Okay, I think that's pretty good consensus. No explosions, guys. We're gonna get a puff of smoke on this one.